Good morning, good morning. First of all, thank you so much for taking time to come this morning. But more importantly, thank you guys for your interest in serving children and families who fall under the spectrum. As you probably know, I'm sure many of you, if you have a family who has a member with autism, you probably have a family with more than one child who has some degree of autistic spectrum. I'm a child neurologist, but for many years I was a private pediatrician, and I know what it feels like to have 30 to 40 to 50 to 60 kids in a day, and somewhere in the midst of that you have to do an MChat or comfort a mom who's crying. It's very difficult, so we want to be of service to you folks the best we can. I'm a child neurologist with particular interest in neurology. Specifically, I'm a neurodevelopmentalist, and we're going to talk a bit about that. So here we go. Let me disclose that we do get money, my center does, from the NIH. We're also doing some Fragile X research for Seaside and from NARSAD. We have one book that we'll disclose that is out there. It's written specifically for pediatricians, by the way, because having been there and encountering a lot of similar questions, I know how difficult that can be. So one of the things that is striking about neurologists is that we're part being called the nerdologists of the world, in which we embrace our inner nerds, but we're also the realtors, right? We like location, location, location. And neurology grew up as a field in which we would name diseases after the locale in the brain or central nervous system from which a disease arose. The difficulty with autism, of course, is it's from the 19th century psychiatric literature specifically to schizophrenia. And the psychiatrist, and I struggle with German vowels, so please forgive me, Dr. Bleuler, close? Bleuler, I can't say it. There. Back on? Yes? I think I will hold this. Okay. So the 19th century psychiatric literature referred to autism as folks who had schizophrenia, and near the end of their lives, much of the positive symptoms of schizophrenia burned out. You had quiet people who would rock, who were self-isolating, who were alone, and the term was called autistic or autistoid. And so when Dr. Connor, who Dr. Wiles referenced earlier, came along, he borrowed that phrase from the 19th century psychiatric literature. Now, having said that, when you come to neurology, that's a little uncomfortable because we don't know where that lives in the brain, right? So we tend to split it up between syndromic versus primary autism. So syndromic autism, sometimes secondary autism, then comes about secondarily to a known cause. And this would be anything that's readily discernible and can have either physical or imaging features such as epilepsy or certain genetic syndromes. Certain examples include tuberous sclerosis, Angelman syndrome, Williams syndrome, Fragile X, velocardiofacial, and others. Primary autism is sometimes called idiopathic autism, right? It simply means at the moment we don't know why this child has an autistic behavioral phenotype. There's not any readily identifiable biomarker, nothing etiologically specific. The thinking is along this line that as we discover more and more causes for this autistic behavior, whether it's a serotonin link or whether it's these other combination of genes, whatever it is, we will gradually reduce the number of, quote, unknown primary autisms to truly specific syndromes in which autism becomes the most commonly manifest phenotype. This is actually on the wrong slide, I apologize, but Fragile X is an example of syndromic autism, not primary, and as such is the single most common single gene cause of autism. So what's a PCP to do, right? I mean, you're covered over with kids. And I know that Dr. Wiles earlier reviewed early detection. We had a wonderful talk then from Dr. Rollins about language interventions. But this is coming straight from the American Academy of Pediatric Guidelines for Surveillance. And so I'm sure much of this is familiar. Just to review quickly, no babbling, pointing, or other gestures by 12 months. That's you review for autism. No single words by 16 months, no two-word spontaneous phrases by 24 months. I think the take-home point, though, is consistently any loss of any language or social skills at any age means that this child has failed level 1 surveillance. If the child passes level 1 surveillance, then you screen again at the next visit. If it fails, then you obtain a formal hearing exam, screen specifically for lead if pica is present. And you would think in 2013 there wouldn't be much case for pica, but we still pick up cases of lead poisoning. And certainly specifically screen for autism, such as an MCHAT or a GARS. This is when referral comes in, and you have a child now who's not passed his level 2 surveillance. You're going to refer to the local intervention or ECI program or to an autism specialist for a formal diagnosis. And this includes formal diagnostic procedures and a neurologic exam, as well as expanded serologic and in some cases radiologic, and in some cases things like EEGs and evoked potentials. So this is all part of once you've referred when they have failed level 2 surveillance. So one of the things that's interesting about looking at neurology in the context of autism is that, of course, autism is one of several features that we see in lots of conditions. And I'd like to just talk quite briefly about some of the more common ones, because I'm sure that you guys see them in your office all the time in some situations prior to the onset of language difficulties, or the language difficulties are so subtle that the other issues are more prominent. That includes issues such as seizures, chronic GI problems, and this can be either chronic constipation or it can be the other chronic diarrhea, loose stools, motor delay, coordination delay, and intellectual differences. So 25% of children who have true autism will develop seizures. It doesn't mean that they'll be refractory seizures. It doesn't even mean that they'll have more than one seizure, but they have a high risk of having at least one seizure in their lifetime. Now, the most common seizure that we see, quite frankly, are not the generalized tonic-clonic events, but rather the absence spells in which a child will have a sudden cessation of motor activity. They stop, they drop a toy that they're playing with, and they come right back. But if you have a child who is already behaviorally odd, doesn't make good eye contact, that's often something that gets missed. So when we have children who have a delay in language, certainly we know that there are acquired syndromes of aphasias coming from epileptiform foci. That becomes an important reason then to get an EEG. These can start typically in early childhood, but can start as late as adolescence. Our epilepsy colleagues will tell us that there are two main ages in which epilepsy presents in any child, and that tends to be in toddlerhood, ages 2 to 4, and also then at onset of puberty. That is also true for individuals with autistic features. Complex febrile seizures are also more common in children with autistic spectrum disorders. What's a complex febrile seizure? Well, it's a seizure that lasts for more than 15 minutes and may have a focal finding in the context of fever. Not necessarily high, but as all of you know, most often on the ascent as the fever is going up. Now, I'm sure all of you have seen this, where you've had a child come in to see you and they have some autistic features, but they also, the mom will say, he's constipated, he won't go to the bathroom, we can't get him to go, it's as though, is it a sensory thing, is it a GI thing, we don't know what it is. And it's not your imagination that children with autism are overly represented with GI distress. 4% of neurotypical, if you will, children have chronic GI issues. Up to 20% of children under the spectrum will have GI issues. Children with regressive autism are particularly at high risk. And so when you have a child who may be a little socially delayed, not even regressed, just not progressing as well, and you feel like you've got this child who you cannot get them clear. You've done all the bowel prep you can think of, you've sent him to GI, he's still not good, maybe there is still value in going ahead and referring in for an autistic evaluation as well. This is what has really intrigued me, and it was a real puzzlement. About 3 years ago, I had a child come in who was falling a little bit, somewhat, but mainly the issue at 3 years of age, he clearly had autistic features. He had gaze avoidance, he didn't have speech, and oh, by the way, he would trip sometimes. And sure enough, we got a CK level that was off the chart, and sure enough, wound up getting genetic screens, and he did have a Duchenne's muscular dystrophy. It's now a well-known phenomenon that for some reason the dystrophin molecule absolutely impacts the development of CNS matrices and social and communicative devices or networks with children. So one of the things I would urge everyone, interestingly enough, the CK level, creatine kinase, is not on the routine chemistry panel for children, right? You have to specifically think of it to order it. So if you are getting a child who's come in with autistic features and they're a little clumsy, don't hesitate to order a CK. That becomes particularly germane if you in fact want to get an MRI. Why is that? Because if they're little, they're going to need general sedation. And if they have an undiagnosed Duchenne's, you don't want to use a general sedation if you can keep from it. So there becomes all of a sudden real value in being very cognizant of motor delay in these children and checking the CK level. It happened, I think we've diagnosed, 3 or 4, Dr. Morris, in the last few years. Again, children presenting with their autistic features before they ever present with their motor delay. So up to 70% of children with myotonic dystrophy who have autism, have a degree of autism, and it varies in their penetrance. A third of children with muscular dystrophies also have autism, as well as intellectual delay. They don't have to have both, and some studies have suggested that depending on which end of the dystrophin molecule has been impaired will determine whether you get more of an impaired cognitive profile or whether you get more of an autistic phenotype. And again, the research is very active here. We're unclear why the dystrophin molecule would impact the CNS, and so for that reason we routinely check CK levels in children who have any complaints of motor delay. So to talk about autism and intellectual differences, one of my heroes is here in the crowd. There are many advocates here, and I wish we had time to acknowledge you all. Dr. Ray is here, and Dr. Starnes, and Dr. Starnes was making the comment that isn't it remarkable that over the centuries we've had these brilliant people who might have been quite odd produce things that changed our lives. And so to a certain extent, I absolutely embrace the hallmark of the Asperger's group that says, don't change us. You know, we're who we are. And while I applaud that, I would also say, I don't want to change you, but I do want to give you choices. We want to make sure that you have the option to participate in social skills or social events. So when we think about intellectual issues in autistic children, and Dr. Morris is going to speak on this quite eloquently here in a minute, 70 to 80% of these folks have some degree of mild cognitive impairment. Now, to say that is a little misleading, because I think the better thought is that they have splintered strengths and splintered weaknesses. They are not predictable as a lot of the neurotypical folks are. 15 to 20% have a profound cognitive impairment with IQs below 35. 10% or greater will have a higher than average IQ, and then less than 1% are truly, as we would consider, savants. The old-fashioned word, which I think is pejorative and we try not to use, is idiot savant, referring to the autistic feature. But I think simply to use the term savant is appropriate because these folks, this very small percentage, they are brilliant, but they are quite impaired in how they can get through day to day. I don't know that my older sister was a savant, but she was quite autistic, and she died prematurely because she was completely oblivious to her own physical needs of cancer. But at the time of her death, she spoke something like 17 languages and had translated the first 5 books of the Old Testament in her own version of the Hebrew. I mean, she was brilliant, and she was the go-to person in the library where she worked on some very detailed things. But she did struggle with knowing how to comb her hair, and wonder when, say for instance, girls, when she lived in the dorm, would come into her dorm room and steal her personal items, would call home and say, why are they doing that? So we get very interesting people who are brilliant with their intellectual prowess, but at the same time are quite vulnerable to society. So what do neurologists do? I mean really, much of this belongs in the psychiatric world, but neurologists have come along saying, you know, the brain's pretty interesting in these folks who have autism. And so over the years, a subspecialty has developed called Neurodevelopmental Disabilities. And I thank UT Southwestern for allowing me to come in and create a fellowship here. We have now one of 9 fellowships in the country at UT, where all we do is train those child neurologists who want to be good at taking care of folks with cognitive issues in our program. And we've got 2 outstanding individuals who are coming through the process, and I'm very excited about them. But it does take a while to get done. There's fewer than 100 board-certified NDD specialists in the country. So our role, quite frankly, to echo Dr. Wiles' comment, is to help train those of you who may be interested in coming in and doing a week or 2 weeks. We're happy to work with you to structure something. But mainly is to get support for you guys so that you have someone you can call, and you do have a place you can send children that really are challenging and need more than, say, what a primary office is prepared to do. We serve to investigate underlying organic causes of autism, and we want to support our pediatric and family practice and advanced practitioner colleagues in their day-to-day role in screening just the sheer volume of kids who come through. So NDD was recognized board certified specialty by my academy, the AAPN, in 2000. An NDD residency consists of 2 years of pediatrics, 1 year of adult neurology, about 18 months of child neuro, and 18 months of NDD. We split it up. You're eligible to sit then for your boards in pediatrics, for adult and child neuro, and then for NDD. This is my grandson, of whom I'm very proud. And so it was an opportunity to put Jackson's picture here. He is holding a chick, which I think they're 2 little chicks. So the NDD clinics provide multi-specialty clinics for a variety of conditions. We don't just see children with autism. We tend to think of, again, the realtor neurologist in us. We tend to think of location. So we see not just ASDs, but chromosomal disorders, children who have intellectual delays, cerebral palsy, traumatic brain injury. We see a lot of Fragile X conditions. And then most recently, we've been following the ECMO children, our survivors, who invariably, when they get off their ECMO machine, they tend to be little babies, little preemies, often have altered cognition. So we're in the process of applying for grants to follow. There have been nearly 500 ECMO survivors in Dallas at Children's. We have of those about 50 in our clinics that we're prospectively following now to trace that. We've got clinics both at the Dallas campus and at the Legacy campus, which is in Plano, and we accept Medicaid. We try very hard to accept all children regardless of capacity to pay. The referral process can be challenging. Anyone agree with that? Yeah? No? Yeah? All right. So as I understand, Children's requires that the primary care physician make the referral. That's the one thing that we have to have in order to have a child come in. So what will happen is we'll have someone say, you know, my hairdresser's grandmother has a child that she knows, and would you see them? Absolutely. Can you get the primary care physician to send a referral to us? And that will start off the process. We have, between us, we all serve as caseworkers at the moment to review the packets that come in. If we get a packet that looks like it's really more psychiatric, this is a child with affective issues, more mood issues, we really can't see them. If they are a mild delay, we may not see them. What we're looking for in the referral is you really need to see a neurologist who's a specialist in development, because all of you out here are specialists in development by virtue of your field. So we're going to trust what you send us, but we want to be able to bring something unique. And so if you can say what that is, that makes it really much easier for us. We screen the packets, and as noted, if we have to turn it down, it's because we either need additional documents or it's not the right patient referral. Our initial appointment takes 1 to 2 hours as a rule. We certainly do an assessment. We get a history and physical. And at that point, we make a determination, what do we want? What do we need to get? MRIs are notoriously low yield, so unless we find something on physical exam, we typically don't get one. EEG is the same thing. It's very stressful on these children to get leads hooked up to their heads, stressful for the technicians. I think they've been called Pat Evans specials when they come down the hall and they're screaming and they're yelling because they're trying to put leads on their head. We certainly do intake for speech, for OT, for physical therapy. We review medication. I'm always open to what you as the primary care physician wants to do with regard to medication. Some folks are very happy to manage the meds themselves, which is great. Or if you want us to make some suggestions, we're happy to do that. I tend to defer to what you, the referring physician, want me to do. And so making that clear in a referral is helpful. And then patients, we get a second patient schedule. Typically, if we've ordered a lot of labs, such as Fragile X or microarray or other tests, MRI, EEG, we will call the family with the results as we get them in, but then we try to see them back within 1 or 2 months to then check and see where are we. For me, it's kind of a triad. The first thing's environment. How's the environment fitting? The second thing is therapeutics. Are you getting the right therapeutics? Are you getting ABA, OT, PT, speech? And then the court of last resort for me will be medication. And I know Dr. Wiles talked briefly on medication choices, but we still tend to leave that for the last resort and to make sure that he's plugged in, the child is plugged in to whatever therapies he or she needs in order for the medication to be most effective. The second visit typically lasts anywhere from a half hour to an hour. We review all the test results, treatment recommendations, medication management. I should say in the midst of all this, as we have been moving toward a large autism center in which we are all housed, I've had the great good fortune of working with a tremendous individual, Dr. Mary Ann Morris, who has been able to get a lot of our assessments pulled together in the context of our work. Now that as we're moving in with psychology, psychiatry, my hope is that she gets to go home at night before 10 p.m. and actually has assistance, right, Dr. Morris, in getting a lot of these children screened. So not only are we reviewing the organic data, but we're also reviewing the psychometric data that has been done both at the schools as well as in the private sector, as well as whatever additional testing we need to do for our children. So tests that are commonly ordered, nearly all of our kids, girls and boys, get a Fragile X screening because it is so common, number one. But number two, we are on the threshold of what I think will be molecular repair for the Fragile X molecule. So not only is it common, we have reason to feel like there's going to be hope on how to treat these folks. EEGs are obtained when we get a history where there's a sudden loss of language, or if there's any history of staring spells for which the parents have no explanation. We prefer MRIs rather than CTs. In the absence of any Duchenne's muscular dystrophy or elevated CK, we get a lot more detail that way. And then psychological and academic testing. I'm going very fast because I have a lot of data. Please forgive me if I'm going too fast. Are y'all with me okay? Yeah, okay. So this to me was interesting. About 5 years ago, the Chiganis started a research site, and their thinking was that their initial PET scan work suggested that children who didn't have autism really, and that's going to be in the darkly colored spots, made a lot more serotonin than children who did have autism, and the children who were neurotypical made a lot of serotonin, and somewhere by age 10 it dropped off. By contrast, children with autism didn't seem to either make as much autism or they couldn't get at serotonin that was stored. Whatever the reason was, serotonin was not where it needed to be in order to help brain development. So their study was to look at replacing serotonin in the form of an old drug named Buspar. How many of you remember using Buspar ever? Yeah, usually, I mean, I was taught to use it for smokers who needed to get off cigarettes. I mean, it's not that great a drug, but evidently, this is the drug of choice. They were able to get PET scans prior to the onset of this double-blinded study. The enrollment has now closed. They have 144 children, I believe, nationally. And so my hope is that they'll be harvesting data here in the next few months. But that's been one of the studies that we've had through the neurology division here. We also have a lot of work with doing Fragile X. We're very fortunate at UT to have an individual named Dr. Kimberly Huber who has a Fragile X mouse. She was very gracious. She came to me. She said, "Pat, guess what? We got a lot of Fragile X kids out there. You want to see them?" I said, "Sure, I'll see them." And so we got a clinic started, and sure enough, a lot of these Fragile X people either are asymptomatic, or they had some autism, or they had some cognitive impairment, or they were profoundly impaired. But sure enough, the Fragile X community, both here in Dallas and nationally, is among the most geared up, enthusiastic bunch of folks. So we now have a Fragile X Consortium registry and database. We have a community outreach. We have several clinical trials ongoing. Right now we have the use of arbaclofen that may be a molecular repair for Fragile X children, but I think we will have more of that kind of information in the few months. And then we are hoping to do a parallel study with arbaclofen and mice and children at the same time. So it is exciting to think that we're this close to getting some real help for at least one condition that causes autism. I got asked a lot of questions a few years ago about what do you do when you got yada, yada, yada. And so what I tried to do, list maker that I am, I'm always making a list. I did try to sit down and write a key that if I had been a pediatrician back in the years I had would have helped me. And so this book was written for mainly pediatricians and family practitioners, but certainly advanced practitioners who get a bunch of kids who might or might not have some autism. What are you going to do now? It follows the AAP guidelines for Surveillance 1 and Surveillance 2, but it also just makes suggestions on what you should assess, whether the child is a little one or an adolescent or even an adult, that I hope would be helpful. Dr. Moore certainly was instrumental in this text because, as she will talk in a minute, we get lots of requests for letters, I'm sure you do too, both to insurance companies, to schools, to families, to other places. So we put sample letters in there that we hope would be helpful, that you would not have to start from scratch then.